Good afternoon, everyone. I'm delighted to welcome you all to the session on charting pathways for equitable and resilient health systems. As we embrace the digital revolution in healthcare, it's crucial that we address the disparities and challenges to ensure equitable access and outcomes. The recent pandemic has underscored the urgent need to invest in digital infrastructure and integrate responsible AI for a more resilient health system. In this session, we have two wonderful speakers who will share their insights and experience, followed by a panel discussion. First, I would like to invite Mr. Patota Putra Tambunan, Chief Operating Officer of the Digital Transformation Office, Ministry of Health, Indonesia, to make his presentation on Indonesia's digital health transformation journey and share some success stories. Mr. Tambunan, in his current role, oversees stakeholder engagement and regulatory sandbox development for health innovations. He mentors tech startups in Indonesia and globally, showcasing a commitment to fostering innovation and collaborative initiatives. Over to you, Mr. Tambunan.
Thank you and good afternoon, everyone. Thanks for the time for me here to present about our journey in the Digital Transformation Office of Ministry of Health Indonesia. My name is Patota Tambunan. You can call me Tota for short. Some people call me Potato, but please call me Tota. Thank you.
You certainly woke everybody up.
Good thing. Okay, so yeah, a little glimpse of Indonesia healthcare system. We have roughly 280 million people and 17,000 islands, and the internet users is about 212 million, 1.6 million healthcare workers, 60,000 healthcare facility, and more than 400 health system information. This is actually a problem for us because in one healthcare facilities, the healthcare workers input about 50 to 60 systems per day, every single day, which is a problem for us. Why it's happened? Because the data and the healthcare system is not yet standardized in Indonesia. That's the main problem actually. So with staggering number, we focus on integration of our health information system called Satu Sehat. And the base of this is of course the electronic medical record. And also we develop the module for optimizing the primary health services, where the 60,000 health facilities here is not included with the community health centers, which consists about 300,000 of health centers for the primary health services. And to achieve that, we built our first digital health transformation blueprint, which released in 2021, and our focus is three. The first one is to individual-based health data integrations by developing the standards for the electronic medical records. The second one, healthcare simplification and digitalizations, as I mentioned before, because we have 400 health information systems, we would like to simplify this into 8 different clusters. And then the third one, of course, the health innovation ecosystem development and support by regulatory sandbox. We have done one regulatory sandbox in year 2023, and this year we aim to do 16 more. So, as you can imagine, it will be a lot of work. And to address the challenge on the ecosystem level, it's not only our task in the Ministry of Health or Digital Transformation Office, but we collaborate, of course, with the Ministry of ICT, the Ministry of Education, etc. Because the first one is the insufficient IT knowledge within the Ministry of Health. So the problem starts within us. How we develop the capacity within the Ministry of Health. That's why the Minister built the Digital Transformation Office, where we try to simplify this 400 system and standardize the healthcare data in Indonesia. And the second one, because the absence of regulations and reluctance to embrace digitalizations, the Minister developed a ministerial decree mandating digitalization with penalties for non-compliance. And also, we put it in our new omnibus law for health, which released on August 2023. And for infrastructure deficiency, we collaborate with our Ministry of ICT to provide the infrastructure not only on the national level, but also on the provincial, city, and district level. By addressing this obstacle head-on, we have successfully, in a way, transforming the Ministry of Health into more digitally capable organizations, which consists of 235 dedicated youths embarking on a mission to transform and revolutionize the digital healthcare in Indonesia. Here, out of 235 dedicated youths, we only have less than 20 people from the health background. Most of us are from the IT background, program management, on the data scientists, on the data analysts, because we will help all of the directorate in the Ministry of Health, all of the healthcare workers on how to digitalize the healthcare in Indonesia. And with this, we are doing the service-based national health data integration, reporting process efficiency, because at the moment, as I mentioned, over and over again, healthcare facilities inputs more than 50 systems every single day. Sometimes they're using the system, sometimes they're using Excel data, sometimes they're using the manual data, and they input it. It will prevent real-time data collection and monitoring, because from the healthcare facilities to the district level, to the provincial level, then to the national level. Of course, it will take time. And then we also supporting the health digital ecosystem collaboration with health industry players to create a healthcare ecosystem that continues to grow. And it's not only for the big players. We also collaborate with different startups, venture capitals, universities, and different associations. And fourth one is, of course, increasing the digital capacity of healthcare workers. This one is the new one, and we are also developing the curriculum, not only for the healthcare workers that are already in the workforce, but from the university level. We are discussing with the Ministry of Education and Higher Education on how we develop the curriculum, because at the moment there's a curriculum on health, but not yet specifically curriculum on digital health or health informatics. That one we would like to change in the near future. And this is the simple, it's the simple actually, even though it looks complicated, it's the simple image of how we build the health information system integration in Indonesia. As you can see in the middle, it's called Satu Sehat platform. Satu Sehat is roughly translated to One Health, but it's not a One Health system, but it's how we connect from different sources. On the left, we have health facilities, consists of about 60,000 health facilities that we focus until the end of this year. And then, of course, from other health industry, from laboratory, biotechnology, insurance company, as well as startups. We are at the moment integrating telemedicine startups, 14 of telemedicine startups. That was part of our regulatory sandbox to be integrated with Satu Sehat. And also, from the Satu Sehat platform, the data will be utilized for three parties. The first one is, of course, the society, where the society, the citizen, can access their personalized medical record through Satu Sehat mobile, which they can access via Android and Apple. And then for the government, they can access the aggregate or even by name, by address specific data for specific intervention through Satu Sehat data, which will provide different kind of dashboard for the government, from the national level, provincial, city level, until the healthcare facilities level. And of course, the third one for healthcare facilities, they can also access the medical record for the referral. If someone from the primary healthcare get transferred to the secondary healthcare, or if someone move from one city to another, the data can be accessed by healthcare professionals everywhere. And to do that, we developed the health data standardization. Of course, we using the international terminology, ICD-10 for the diagnosis standard, ICD-10-CM, SNOMED CD, Boeing, DICOM, and KFA. KFA is the new standard that we're developing to standardize the drug nomenclature and also for the medical devices. We have more than 20,000 medication data and more than 150,000 of medical devices data that we standardize, and it's already implemented in all pharmaceutical industry as well as the health medical devices in Indonesia. And then, not only the standardization of health data, we also developed the master data. The master data, the first one is of course the master patient data. The second one is the master facility for the health workers, pharmaceutical medical device, master funding and service data. If someone asks, why do Ministry of Health develop their own master data for the patient? Why not use just the national identity? Well, because the national identity is not for everyone. Let's say the case newborn baby. Newborn baby will give them the national ID after they are registered to the public registry. But once they are born, they get screening, like the screening for the congenital hypothyroid and other screening for newborn. They need to be registered to our master data patients. So that's why we develop our own master data for the patient. This is what have been implemented in these 2 years. Satu Set Nawa have been accessed by more than 100 million people, and for the healthcare facilities, we have more than 23,000 health facilities integrated with Satu Set. What does integrated mean? It means they send their real-time data to our system, and at the moment, we're seeing about 7 to 10 million health data per day. 7 to 10 million health data per day to be interoperable within the Ministry of Health. And for the sandbox development, we already done the first cluster, telemedicine, out of 17 target clusters. So this is also one of our big job to ensure the regulations is implemented to all new emerging technology that will be implemented in Indonesia. Other than that, on the bottom left side, you can see we also have the BGSI, Biomedical and Genome Science Initiative, which focus on 8 main diseases, 9 genome sequence facilities, and running 8 biobanks within Indonesia. It's just started in the mid-2022, so it's not even 2 years old, but we are at the moment targeting 10,000 whole human genome sequence to be registered to our database. And for the ASIC is like the mobile applications used by the healthcare cadres, the volunteer in community level to input the data for immunizations, for the maternal health, for the neonatal health, and it's for the individual immunization record. Is already almost 190 million immunization record within the ASIC. And for the screening, we also have done more than 84 million health screening for non-communicable disease within Indonesia. And it's being done by 1.2 million health cadres in Indonesia. This is our next step to expanding the physical border to recognize healthcare in Indonesia. You see here is our progress on how mother being checked with USG, either it's Puskesmas, either it's in the healthcare facilities, either it's in the hospital. They will get the data of their USG directly into their WhatsApp. It's pushing another breakthrough because the data is standardized, and we also put some bullet points on what they need to pay attention on, and it can be used also for the healthcare professionals to do follow-up to the mother in case of something happened with their health. And also, we also doing the malaria prediction and child measurement report. It's using data from ASIC that is being used by the cadre, and also we can predict about what will happen. Will there be like malaria outbreak? Will there be what kind of specific intervention that we need to do to prevent stunting? Because stunting is still one of the main problems in Indonesia. So the notification will be sent through WhatsApp, not only to the citizen, but also to the cadre as well. So they know which specific community group need to be supported. And this is the work that we have been done since like mid-2023. And also we are developing the status health map to show the geographical information system on specific diseases and specific area to monitor based on the region. And if you talk about what about the data security, of course we comply on three aspects here. The first one is law number 19 on electronic information transaction, and we also comply to the law number 22, number 27, which is on the personal data protection, and also we put the standard of health data on our new law on health number 17 of 2023, and this is to ensure the standard of security not only on the national level on the Ministry of Health, but we also developing the standard for provincial level, for city level, and also until the healthcare facility level. It's still a work in progress, but we are already developing the guiding principle to develop the health security, cybersecurity regulation framework in Indonesia to be implemented not only on the ministry level, but also on the sub-national level. Of course, as for our commitment, we already certified ISO 27001 as well as ISO 27799 for the health, and it's just to showcase our dedication from Satu platform to maintain information security in the healthcare industry. And to implement it, of course, we put like several guiding principles from the collection, processing, storage, distribution, and utilization. And also we classify it on the, as I mentioned, national level. And national level is not only Ministry of Health. We have Ministry of ICT, we have Ministry of Education, we have Ministry of National Development, Ministry of Internal Affairs. They also using our data, so we use our data classification on this aspect to different ministries as well. Now, if you heard about Indonesia, we just had our election last month, 14th of February, and people are asking, what about after the new government? Will you continuing do digital transformation? The answer is yes. At the moment, we are building our new blueprint to 2025 till 2029 digital health transformation strategy, and we are collaborating with the UK through the British Embassy and Tony Blair Institute to bring the second digital health transformation blueprint, which we will focus on three things. The first one is health enterprise architecture. How about the second one is the data governance, and the third one is health institutional capability. I would like to highlight the third one, the health institutional capability, because we will focus on the national level, as I mentioned before, not only the Ministry of Health, but specific directorate in the Ministry of Health, and then the other ministries that will use our data. And then the third one is the regional government, which is the provincial level, city level, and district level. And then the next one is also for the healthcare facilities level, with the hospitals, community centers, laboratorium, etc. And of course, the fourth one that we will add is with the international partners. From the international NGO, for the international bodies like WHO, CDC, etc. We also developing how we develop the enterprise architecture for all stakeholders and how we develop the institutional capability from within us to serve better all those stakeholders. And digital health transformation vision is to deliver effective and efficient national health efforts in all over Indonesia. We, at the moment, are preparing the implementation plan for those 5-year blueprint, and hopefully it will be ready within the third quarter of this year. I think, and also would like to mention about our statement during our general meeting with the Asia Health Information Network last November in Jakarta, where Ministry of Health of the Republic of Indonesia will work together with our national insurance, BPJS Kesehatan, as well as the Asia Health Information Network. We recognize the importance of increasing investment in digital health infrastructure, and also we encourage development of digital competencies framework, not only from within the health sector, but also from other sectors, from education sectors, for the technology sectors, and also other social sectors. And third one, we recognize the significance of health data governance, which we will put within the digital health transformation strategy blueprint. And also, we We'll push collaboration across diverse sectors. At the moment, we have done with different stakeholders, different ministries, different startups, with venture capitals, with healthcare industry, international partners, and we will push more collaborations across diverse sectors. And the fifth one, standardized practices and interoperable system. As I mentioned, we have more than 400 systems. We would like to simplify it to 8 different clusters. And at the moment, within the Satu Sehat ecosystem, we have more than 480 private systems, which is developed by local government, which is developed by startups. They will connect it through healthcare facilities to Satu Sehat. So all healthcare facilities can use whatever system they like, and as long as they are standardized, they will connect with Satu Sehat system. And then we and also support active engagement and encourage countries to set up sandboxes to strike the balance of innovation and regulation. I will open this for discussion within the sections, because also one of my focus is the regulatory sandbox for digital health. We already done the telemedicine, and hopefully we will discuss about other type of regulatory sandbox during the session. And yeah, collaboration holds strategic role in the hastening the health transformation, and we are looking forward to collaboration with all of you guys. Thank you.
Thank you, Mr. Tambunan, for that insightful presentation. Next, I would like to invite Mr. Ganesh, Udayasankaran from Asia e-Health Information Network to present on the importance of partnerships and multi-sectorial participation for digital health. Mr. Ganesh serves as the Executive Director of Asia e-Health Information Network, AHIN, and brings 19 years of expertise in implementing enterprise digital health solutions. His vast experience includes spearheading projects like web-based hospital information systems and telemedicine. He's engaged in various global committees, including the Global Digital Health Network and Global South e-Health Observatory. He contributes to normative guidelines and toolkits for digital health and telemedicine by organizations like WHO, ITU, and IMA.
Good afternoon. I'm thankful to the previous speaker who has highlighted the topic of my discussion, and thanks very much. I'm inspired by what Dr. Reddy said this morning about learning and action. I represent a learning network again, this Asia e-Health Information Network. We started with 6 volunteers way back in 2012. Right now, we are 2,300 plus. And then, while our primary focus was supposed to be the WHO regions of Southeast Asia and Western Pacific, now we have members from more than 81 countries. And that could not have happened but for the learning, the collaboration and the partnership. Because in digital health, that is something that I would like to highlight in the next 10 minutes. Digital health is inherently multidisciplinary and then also multi-sectoral. That makes partnership and collaboration inevitable. Means I don't see a way out of that. Everybody is doing something, but our idea as a network is, why not we build that kind of a bridge where we can all do something meaningful together. That has been the journey of AHIN so far in the last 12 years. So I was just mentioning about our network, and this was like a year ago when we met together, and then we also had a workshop together with our working council members. AHIN also consists of all sorts of members, like people from academy, the policy makers, the Ministry of Health or Ministry of IT representatives, academy research. So we have representation, active representation from 14 countries in the region, though we have a larger presence, but these 14 countries have the working council members who collaborate with us on a daily basis. And just to show you a study that was done 3 years back. And this is I think very well known to us. I don't think we need to stress that when we compare to other sector, the healthcare, the digitalization in healthcare has actually been a bit stagnant. And there are many reasons that also, like, the report points out about the healthcare systems are experiencing increasing demand, which we all know the constraints in supply. And also there is a need for harnessing the data and to digitize the front end, augment the back end. And scaling data, digital and AI for impact in healthcare systems requires collaboration, which again, like what we are going to discuss now. And healthcare systems need a strategy for prioritizing. Like in AHIN, we come across broadly two situations. There was a time 10 years back, we come across countries which did not have a national digital health strategy. So we started working with them and then helping them to create a national digital health strategy to have their vision. But now we have come across another situation where the countries do have the strategy and the blueprint, but it has been more as a PDF or a paper. So this is where again AHIN actually is working together with them to translate that into practice. That is the reason that in my previous speaker Tabu mentioned about the work that we did together in the last year in November. We had the AHIN General Meeting in Jakarta. The theme was focused on putting blueprints to practice, because we worked together with actively, I think, 4 countries in the region who already had strategy or a blueprint and then had challenges or in the process of implementation. So this report also shows an idea how coordinated care can be if we leverage the digital and data, and then also talks about the enablers, the 5 enablers that we can focus on to bridge those gaps. This is another work, the Global Digital Health Monitor. Previously used to be known as Global Digital Health Index. It's by Health Enable. Right now it is in the process of, WHO is in the process of absorbing this as a benchmark. And then we actually are one of the collaborators. So 12 countries from the region, we helped to work together and collect the data. So this report was published during the Global Digital Health Forum last December in DC. And this data is out of analysis of 67 countries that participated. So if you can see that 56% of the countries either do not have established digital health governance or functional governance, and then 75% of the countries either have started development or approved national digital health strategies, which is a good thing. And 73% of the countries either have no visible private sector participation in digital health, or participation is in ad hoc manner or limited. Pre-services digital health training for health professionals is not in place for half of the participant countries. I think this is another thing this report came up with. These indicators, there were 23 of them. They were all based on the 7 core digital health building blocks, which WHO and ITU published way back in 2012. And this particular area of the health workers, like health professionals being digitally capable or skilled to be able to take up this task, was a major drawback across regions. Across all the 6 regions of WHO, this was one parameter that was very evident that this area really needs support and attention. A third of the countries do not have plans for maintaining digital health infrastructure. We have plans and we have invested in projects, but when it comes to the infrastructure or maintenance of what was undertaken, there has not been sufficient investments or effort on that. And there is a wide regional disparity in terms of investments in digital health, artificial intelligence in healthcare. As I think we all know that 90% of the countries do not have regulations on that front. And architecture for standards and interoperability still remains a challenge. And 27% report that they do not have standards for digital health transmission, messaging, standards, security, privacy and hardware. This is just to give you an idea of works that have happened, the analysis that has happened across the countries, where AHIN comes into picture. This is where, like, we have started something known as a convergence approach. This we learned in a very hard way, because we started as a humble network with providing webinars for our member countries. Webinars used to be weekly, monthly. We used to give specialized topics based on the demands from the membership. Then we also started training our members in terms of governance frameworks, standards, interoperability, got them certified. But then we found that's not actually been very useful for the country, because if they do not have a career pathway defined in their own countries, nobody is going to stay. Or whatever we train, those health workforce, whoever has been trained may or may not stay there, or they may not be able to actually put them into practice. So that's the learning that we had. I think the first training that we ever provided was on HL7, way back, almost 10 years back. Then we realized we trained a whole lot of people, but they were not able to put that to use. That's where we learned in a way that we put also a re-entry plan. Now any country whom we actually select those participants, we have the nominees coming from preferably the ministry, because unless otherwise they have a plan of what they learned from this course and then go and then put back into action, there's no point in actually training them. So in the convergence approach, we bring together different ministries. Basically, as I said, in digital health, it's not only the Ministry of Health. In some countries, it's Ministry of IT or Telecom, and then the Ministry of Planning and Finance also plays a very important role, especially when the aid coming in from elsewhere. And then there was one particular country that we were working together for the National Digital Health Strategy, and the Ministry of Health did not have an enterprise architect, but there was one architect available in the Ministry of Telecom. We were able to bring them into the picture. So basically in the convergence workshop, we have a toolkit which I will be talking about. We bring together multiple stakeholders relevant for digital transformation, or I would say that digital in-health transformation in the country. We bring them all together and get them to see a big picture, because sometimes even within the same ministry, different departments have not been aligned, or they are not in sync of what they want to do in terms of the digital in-health programs. And so in general, we bring together these different partners together, the different ministries together, and then also there are two occasions in which we help them as part of the convergence workshop. One is the country does not have a digital health strategy or a blueprint with a cost plan. Second, if they have one, but they have not been able to actually implement it or take it into operations. On both occasions, we use this methodology with different sets of tools, and then we help them to realize. It's a work in progress. We have so far done in 9 countries and working actually with 3 of them actively right now as I talk. We had one convergence workshop in Philippines 2 days back, and we will have one with Mongolia within less than a month. 3 tools that I talked about. One is this GAPS framework, which AHIN has evolved, and then the other one was WHO National E-Health Strategy Toolkit, which has been there for quite a while, and then the Global Digital Health Monitor. In terms of the convergence workshop, what happens is at the end of the workshop, the stakeholders within the room or the hall, they actually decide to work together. That is a very big challenge of making people working together. That's what we try to achieve. So everyone gets to know what they are doing within the country, because landscaping also happens, digital health landscaping also happens during the meeting, or usually it is done also as a pre-convergence exercise and discussed during the meeting, and then everybody knows whom else they can work together with. That is something that we try to achieve. And then if the strategy is there, we align the resources in such a way that everybody agrees that now they will work together in the national implementation of the digital health strategy. So this is in short as a description about the process. So how AHIN actually gets involved? Because we are a network, we consist of volunteers from different countries, but how do we get involved? The host country, the country which is interested in conducting a convergence workshop, they write to us. They write to us and request the support. Then together with them, we actually put together a set of development partners, because this has to be funded. Somebody has to support. And then there are already partners working within the country. They may be doing the same thing, like maturity assessments, landscape analysis. And so we actually work together with them and then plan the entire workshop and then the agenda. And implementation here means the conduct of the workshop. And then it doesn't stop. AHIN's role doesn't stop with just conducting the workshop, coming up with a very nice set of recommendations, but we also have something known as a follow-up. The follow-up means whatever has been agreed, there could be 100 things that could have been listed as to be done. But in that, we actually break down into smaller chunks, like short term, medium term, and the long term, and then we align or get the commitment from the partners, like World Bank, say WHO, ADB, GMF, or any other partners. We actually tie them up with that and then say who will, based on who is willing to support what, so that the strategy is backed up in terms of investments or support either in funding or beyond the funding means. So this is one framework that we use during the AHIN's Convergence Workshop. There are plenty of frameworks and tools in digital health. So there is no dearth of that. But we found this to be very simple. This is something that came out of the AHIN's meetings and interactions, our interactions working with the countries. We find in this 10 plus years of our work together with the countries and partners, the issues or challenges in digital health could be broadly categorized under these 4 categories. Come what may, like, different toolkits, different frameworks, but essentially these 4. One is governance, and then the architecture, people and program management, because we listed earlier it was only program management, but we listed people because this capacity, the inhuman capacity for digital health, is something that is really missing or inadequate. So we started listing them separately. And then of course standards and interoperability. We encourage the countries to actually mine these gaps, means identify such gaps in the country, and then we help them to fill that in terms of supporting them in the National Health Information Foundations. We had this call for action last year in Kuala Lumpur. We gathered our working council members from 14 of the countries. We sat together with them over 2 days and got those inputs of actual challenges that they are facing in the national digital health transformation. Because some of them nowadays have some unit called program management unit or digital health unit. Some of them still do not have, but they have translating their projects into programs now. That's where the problem comes. When there is a 1 or 2 projects, it's easier to manage. But when it comes to a large program, which especially, like for example, think about a country like India and Indonesia, where the health is also a state subject and then it's also a federal level, the challenges are much more. But many countries are not that large, but they have started this program, but still do not have a dedicated team for digital health. It's like in some countries, the digital health is managed by the team that does statistics, or some other unit within the Ministry of Health does this as a part-time effort. That doesn't work. That's where we launched this call and then had this framework discussed with them, and we also have collected some case studies which will be actually available. This particular version of the GAPS framework, we call it 2.0 version. The white paper is already available, but a more refined version and an endorsed by the countries will be available by this end of this month. So again, these are well known that the issues with governance, but since this event also focuses on resilience, I would like to leave you with the thought that what happens, so much of effort happens and investments happens in digital health, but when a transition in the political leadership happens in a country, what happens? I think that is something that we need to think. This was also discussed during recently we had this digital health workshop during the Prince Mahidol Award conference, where there was a session actually focused on governance in digital health. And there also we discussed about the role of resilience, especially when there is a political leadership that changes, because the whole team changes. All the capacities that has been built in the team by networks like us, and then the effort that has been put in by the previous team may get lost. How do we actually build this kind of a resilience in the governance of digital health? And in terms of program management, our prescription, or I would say suggestion is the Ministry of Health invest. It could be a very small team. It could be just a 2-member team, or as big as the Digital Transformation Office in Indonesia. It could be anything based on the capacities and the vision for the country. But if they have a team that focuses on taking the digital health transformation in the country, because there is a governance layer, there's also an operational layer, but there is no one, like a connective tissue to tie between these 2 layers. This we find in every single country that we have been working. So for example, one of the countries we worked on a convergence workshop, they didn't have a strategy. We worked with them, and then we had the stakeholders identified, we had a convergence workshop done together with the stakeholders. The country now has a digital health strategy and a costed plan, but now they also have a terms of reference for this team, who will actually make things work by working between the governance and the operational layer. So this actually makes a lot of difference. Something like at the governance layer, like something like a steering committee, they take decisions. But after they take the decision, somebody has to be there to take that to action. Somebody has to call for the meeting. Somebody has to minute it. You know, I'm trying to simplify the role of the program management office, but this plays a very important role. For interoperability and standards, most of the countries now working together with AHIN to have a local interoperability lab. Like, usually we base it in the universities because it's easier that way, and then they're also quite impartial and easy to work together with, have the collaborations. We have some models from other countries identified, we have shared those experiences, and then this interoperability, we call it standards and interoperability labs, and then also building a community known as COIL, which actually brings together the various standards and interoperability labs that are functional or in the pipeline. And this is another area that we have been working together with a partner known as Transform Health, because everybody is talking about data, AI and everything. But then many countries still do not have a regulation that is related to health data governance. There are regulations, but they may not be directly related or govern health data. So we actually worked with Transform Health, and then of course they have plenty of other partners as well, in drafting these principles. These principles are very good, nobody has any issue about it, but then instead of keeping it lofty to look up to, we wanted to actually take them to practice. That is where, right now, we are again working with Transform Health, and of course there are other regional digital health networks also working with them to have this in-country dialogues happening in the region, and then identify those regulatory landscape available in the country, whether it exists, doesn't exist, also what it takes. We call it like a minimal component. That is something that is happening right now, and then the countries, when they go to the World Health Summit, like we want them to actually project it on the agenda of WHO, and then eventually it should take shape as a resolution or a global framework. That is something that we have been working together with. So this is in short the timeline by our partner Transform Health. And as you can see that the networks, the regional digital networks like HEDINA in Africa, AHIN in Asia, and RECAINSA in Latin America have been working together with them. And then hopefully that we should have something between the countries as well as regional, and hopefully by something more global at the WHO level in 2025. And this is the latest initiative that has been launched. I'm sure that many of you in the room may be aware. WHO has been working together, especially with the, it all started with the G20 presidency of India last year, and this idea came up of global initiative on digital health, and it's supposed to be a network of networks. Like we are a regional digital health network, but then there are many other networks. So this initiative is supposed to be a network of networks, bringing all the various networks around the world together, and then for digital health. And this was launched on 20th of February officially, and AHIN is part of that. And one of the primary aim is to have a partnership for country-centered digital health transformation. And this initiative has 4 pillars. And one is country needs tracker, another one is a country resource portal, transformation toolbox, and convening and knowledge exchange. For example, AHIN actually fits into all the 4 pillars of GIH. They call it guide. It's easier to call it guide because it's supposed to guide the countries in the digital health transformation. And now, as far as I know, the call for applications was also released. I think around 880 different organizations that signed up to a few days back. If anyone wants to sign up, I can also share the link. And I think around the World Health Summit, World Health Assembly time in Geneva, further discussions and planning is going to happen to operationalize this global network. And with that, I would like to thank you for the opportunity. I hope I have not exceeded the time too much. If you have any questions, please feel free to ask me. Thank you.
Sharing all the details about the initiatives. Now that we've heard from both our speakers, I would like to move on to our panel discussion. The discussion today aims to cover key topics like equity, policy enhancement, responsible AI integration, and collaborative empowerment. May I now invite Mr. Kiran Anandam Pillai to join us on the stage to moderate the session. Mr. Kiran Anandam Pillai, CEO and founder of iDrishti, serves as the advisor technology at the National Health Authority, actively contributing to India's digital health initiatives, including the Ayushman Bharat Digital Health Mission and PMJAY. Committed to healthcare impact, he volunteers with the UIDAI and iSpirit Foundation and leads iDrishti, delivering quality eye care across 12 hospitals in Karnataka, India. Thank you. Please.
Thank you, Supriya. So we're going to have a good set of panelists, but before I start, can we just check if Kanika is online? And can I invite my panelists over? Ida So Dr. Ida is currently an Economic Affairs Officer at the UN Economic and Social Environment Council for Asia and Pacific. And she's been working on digital, just one second, I'm losing my glasses. Yes, ICT and development, and especially on e-resilience. So we've been hearing a lot about health-related resilience. So time to understand what is e-resilience and what she's been working on. Please around, can I have Edward Booty, do you want to join us on stage? He's part of Reach 52. It's a social impact organization founded out of Singapore, where he's been working with almost 7 countries, working with community health workers, and I'm sure he'll tell us more about that. Online, Kanika, can you hear us? Just wave your hand. Yes, thanks. So Kanika is actually a consultant and strategy. She's a lawyer working with WHO in the Department of Digital Health and Innovation, and she specializes in health law, primarily on national and global. And one of the areas that she's working in, a very interesting area for us today, is on artificial intelligence in health, so the global initiative on AI for health. And lastly, we have Manpreet, busy Manpreet on the back, so please join us, Manpreet, who is the data and AI strategist at Microsoft based out of Singapore, where he's been working with use and advising use of AI in healthcare for a variety of clients, and I'm sure we'll hear a lot about that. So I think, could I also have Patota have you back on stage for this panel? I think in the last 2 speakers, we heard a lot about digital strategies of nations. It was very enlightening to see that both Indonesia and I think AHN has been working with a lot of countries on digital and use of digital. And I think as we all think about digital in our own minds, I think we learned that health is still a bit behind on when it comes to digital compared to many other sectors, and that's probably true. I've been working in digital health for quite some time, and compared to many other sectors, I think adoption of digital has definitely been a bit behind, but I think it's really fast catching up. And I think if I project and look forward over the next few years, I see digital being very integral and part of healthcare very much. But even today, one of the core challenges has been that digital does not touch everyone, and there still exists a large digital divide, so to speak. So I'd like to first request Ida to talk a bit about her work, about what is it that she's been doing, how do we actually look at this digital disparities, and what are the recommendations on how to actually bridge that gap. Ida?
Thank you very much for Global Learning Collaborative for Health Resilient Systems for giving this opportunity for me and Economic and Social Commission for Asia and the Pacific to be integrated in this platform and share our learning. We spent around 5 years, right, maybe 4 years, just sitting behind the screens during pandemic, trying to do a lot of data analytics. and looked at different aspects of policy coherence. And since I have only 5 minutes, that's why I stand up to run through 20 slides, so I can show how do we visualize the very comprehensive set of data and how can digital health systems and platforms could be maintained and sustained for the future. So starting with definitions, I was really impressed with the ITU handbook on infrastructure of digital health platforms. It's a good handbook, it has good data sets and examples, and we looked at digital health systems and also the platform-based approach to see how the data, images, and all information could be of use to improve the wellness and support the ecosystem. So looking at the connectivity and also the internet access, from ICT perspective, we pick up some data sets which are related to speed, and you look at the data infrastructure support mechanisms, and when you look at speed, you also look at affordability, if it's 3G, 5G, if it's satellite images, and based on the issues that the region has, you could see there is a huge digital divide. And if we decide to use the digital informatics or in health systems, we need to see how the systems could be maintained in terms of how to resist and accommodate, adapt to transform, recover from the hazard. We prepared this dashboard, which is has open access to data. It's e-resilience monitoring dashboard. We updated it with new sets of data for 2023. And what is exciting about it, we have 5 different pillars of e-resilience, which is information, ICT, information infrastructure. We look at policy of ICT in different sectors. We looked at data. We looked at new system and applications, and we also looked at hazard indicator. So if you look at the convergence of holistic approach, each of this component, the absence of it and its presence would create resilience. So it's a complex approach. And in the absence, you will see the system would be in rigidity or anxiety when you don't have enough data. There will be resistance if there is no policy, and then there will be frustration if there is no information. So please don't compare countries, but look at how the countries are balanced within these 5 pillars based on the data we collected. So some of them are quite goodly represented through digital infrastructure systems. And some of the countries, you could see that they have the scores that are moderately high in ICT policy serving different sectors. This pillar on new systems and applications is the weakest in the North and Central Asia. At the same time, the data management also low, but hazard and exposure looks like is not a big issue. At the same time, Azerbaijan and Armenia is more exposed. So we visualize the same pillars in the bar chart format. You could also see how this is represented in Northeast and South Asia. So what are the data sets? Yeah? I think we discussed this during last conclave. I will just go through quickly and assure you that we picked up all the data from reputable sources, and now there is a need to update it. And we keep still using the secondary data. So when do we want to create new data sets? Because there is a new index that we also pushed us to work towards. It's digital transformation index. So we lack of data, but why do we look at lack of data? Because digital transformation is built up on digital divide, and there are 3 stages of digital transformation, where we have a digital foundation with access, with the ICT market, with basic skills and basic connectivity. And then when the group of countries with 105 existing indicators show that they have adopted the digital transformation in their current economic endeavor. So an acceleration, digital transformation acceleration is, you see the country is quite inclusive, everybody has access to internet. I heard that Singapore is now investing in each senior citizen to get digital skills. So these are the acceleration of the digital transformation part, which is reflected in policy. And then market is innovative, and the highest aspiration is to create environmental sustainability of the space. So with all these interesting opportunities, we just visualized again the list of policies that country have in ICT and list of their commitments to greenhouse gas emission reduction. So you could see on the left-hand side, e-resilience, digital transformation index, network readiness index with different metric zones. And you see the greenhouse gas emission reduction pledges by 2030, 2060 in CO2, megaton of CO2 equivalent. And what will be the strategy each country group would have to decide? Do they want to use digital and ICT tools? Will it help them to achieve, for example, SDGs? SDG 13 is very behind, and how fast it will be achieved. We went further with our research. We scatterplot the DTI scoring with targeted greenhouse gas emissions reduction in selected countries. You could see the A, B, C, D different sectors. And if the country group want to move from one sector to another, they will have to define their strategy. So for example, from section A, if you remember, section A is on the right-hand side up, where the commitment to greenhouse gas emission is high and the digital transformation index is high. So these countries are China, and you could see other listed, right? Singapore is there. And then what would be their strategy? Do they want to stay in this capacity? How do they want to improve? And then the countries that are on the far left or closer to the bottom left side, they have a lot of amazing opportunities to improve their digital readiness and show their commitments to different climate concerns. So, since we're talking of different multi-sectoral space and different this interdisciplinary approach, we look at the multifaceted and we want to be holistic. So we need to look at leverage points. And leverage points should be also of multiple impact. So those leverage points of multiple impacts, for example, how digital technology can support climate action, so we elicited 8. So we need to create innovation through dynamic mobile digital connectivity. So if we don't have fiber optics, and maybe we need space applications. If we don't have space applications, what do we have? So this kind of things we need to sort it out. We like to increase productivity. Everything is high speed, right? So, but then we need to have agile methods for increasing scale of economy. For example, in energy sector and manufacturing. Promote sustainable consumption production, support environmental protection. So these are the leverage points that are supported by case studies. It's not published, it's coming to the light in a few days or months. So for the way forward, since I'm a technical base, I'm doing research and supporting policymakers, my work would be on preparing the choice of indicators for tracking resilience, looking at climate concerns, and also scoping data for digital transformation index, and maybe prepare the internet speed maps. As Secretariat, we are supporting ministers of digital innovation and technology to join their efforts in common vision during the Asia-Pacific Ministerial Conference on Digital Inclusion and Transformation. Kazakhstan in Astana plans to host it on September, and ESCAP will serve the ministers. So in that space, we would need to see how they can serve other sectors, and if health sector will be a priority, then what will be our messages. That's why I'm looking forward to the report of this global conclave, so we can also sensitize ministers of digital development in Asia Pacific. Thank you.
Thanks, Eva. Interesting to learn about the whole digital transformation index, and also how you're linking that to the greenhouse gas emissions. I'd like to move on to Edward. Edward, I think you've been working with mostly rural communities as part of your startup. But I'd love to understand, since we're still talking about the digital divide and especially your experience and learnings from rolling out digital tools to these communities, and what are the challenges that you see and face as you're dealing with many of these rural areas which probably still are low on the digital index or connectivity side.
Yeah, sure. Hi everyone. So thanks for the invite, thanks for the intro. So I'm Ed, set up Reach 52. 52% of the world can't access basic healthcare or essential healthcare. So we're trying to reach the 52%. Tech platform used by health workers to collect data from their communities, and then they retarget specific households with specific health interventions, e.g., promoting vaccines in certain households or diabetes screenings or whatever. But yeah, health workers trained to collect data, targeted health promotion. Separate part of the business, app for pharmacies to order discounted medicines. So we negotiate discounts from partners. Pharmacies can order medicines. So it's in partnership with government. Health workers engage populations, speak to a government doctor, often commodities lacking available in pharmacies. 7 countries, as mentioned. Trained about 24,000 health workers on the tool now, about 2,500 pharmacies. Big growth this year, so we should be hitting about 60,000 health workers by the end of the year, just over actually. Apps in 13 languages, getting onto some of the challenges, works fully offline, have to support Android version 7, I think, which is 12 years old, this kind of. Going on to the challenges, hyper-localization, offline working, internet often is really bad, intermittent, especially when raining, freak weather, etc. And often the phones people use are, these $50, $80 phones are incredibly low power, older devices, often refurbished, so designed with offline dialects and multilingual, low spec devices in mind. In terms of how we've done this, challenges, been at this for 6 years for what it's worth. Firstly, designed everything with the users, very simple user interface. I guess it goes without saying, but you don't have super swish user interfaces. Time, you don't just turn up and train somebody in 1 hour and then expect it to be done. Multiple training sessions. I think we've done quite well with a sort of buddy system. So you'll often have younger health workers, for example, they adopt, they use Facebook or whatever, Instagram, marketplaces. They can buddy up with some of the older health workers. So you kind of have a peer mentoring network. That's been going really well. Definitely partnership with government. I, as a digital tech founder, we often get, the tech scene is like a silver bullet sometimes, health equity is lacking, rural areas lack access. Let's bring a digital tool. You need to have the government involved. What happens if a health worker sees a patient in the app and they've got a problem? Where do you refer them? How do you train the doctors? What's the, what happens? I often think that tech is just a digital front door to a system in this setting, and you need to make sure there's somewhere to send those patients. So I think not seeing tech as a silver bullet, but more of like an operational enabler to a stronger health system is essential. Because too often people see it as, solving the problem versus just supporting. And I can continue, but I'll pause there. With many more, learnings, but welcome more questions in due course.
Thanks, Edward. That was really useful. I like Patota. One of the things as I was watching your presentation, Patota, was very impressive to see over 100 million people now using the Setu Sahayata. So many healthcare facilities coming on board. You were telling me that it's not just for public health, but it's also public and private facilities that will ultimately participate. But a big question, and this is a big question that looms in India too. Trust, especially, is there fear that the government has access to so much health data in the public? How has that been? What are the regulations, or what are the ways in which you guys have addressed both security and privacy, and most importantly, I think trust. Like in India, as we do the Ayushman Bharat digital mission, one of the biggest pushbacks we get from private doctors is that they're saying, hey, how much information access will the government have about with all of these digital systems and tools that are coming in. So tell us a bit about what has Indonesia done in the space of, especially to build this privacy and trust. Is there challenges with the healthcare worker side? Is there challenges with the people side or the citizen side in terms of this health data?
Yeah, thank you, Kiran. It's a very interesting problem all over the world, if I may say so, and of course, it also happens in Indonesia about the trust. And how we build trust is basically being as transparent as possible. We classify different kind of data, like of course there's general and public data, aggregate data, and then the health data, and then more specific on the medical data. We classify different kind of data, and we develop different kind of data governance on this. And if people question what kind of specific data can be accessed from governments, it will also classify what kind of government are you, like a central government from the Ministry of Health or from our ministry, and then are you like the minister himself, or like specific on the program. We have a different classification on data access as well, and we open it to everyone. If you would like to discuss with us, we have our specific data governance tools and regulations on data access, as well as we open on where we store our data, which data is stored in the public cloud server, which data are located in our private cloud server, and also we develop, I don't know, like hundreds of procedures on different kind of data. We as government only can access the aggregate data. We are not able to access the specific data by name, by address, or everything. We, even me, I cannot access specific data, only aggregate data. And also the same access we give on the all governments. If you would like to have the access specific data, you have a lot of requirement that you need to pass. You need to check your system. You need to check your access level. Who's responsible for this?
Does the data protection law of the country go down to that level of, like, does it give you kind of air cover in terms of all of these guidelines and stuff that you use?
Actually, it's not in our part, but the data protection regulator in Indonesia, they like give it to us. Okay, for health sector, you responsible for it. And other section, education level, you other ministry are responsible for it. So even the data protection is decentralized. Yeah, decentralized in Indonesia, and we build our own standards. And as I mentioned before, we already comply with two ISO 27001 and 27799, and yeah, we are at the moment developing our guidelines how to comply, not specifically to ISO, but the principle of the ISO for the healthcare facilities, for the regional government. And we do it as transparent as possible. That's how we build trust. If we keep it in a black box and no one knows what we're doing, of course we couldn't develop trust from the ecosystem, not only for the healthcare facilities, but also from the regional government and also from within the ministry. If we have no transparency, how can we expect them to trust us? So the first guiding principle is being as transparent on what technology we use, where our store data, and what's the procedure to protect this data. Hopefully that helps.
Thanks, Tota. I think data and security and privacy is going to continue to be. We're going to have many conferences, and I think every conference is going to keep talking about data privacy and security in healthcare. But I would love to hear, Manpreet, you've been part of Microsoft. You've been building, I think Microsoft and many others have been building very large language models, which is all, of course, built on the top of data in many ways. So give us a sense of how are large corporates approaching this issue of data privacy and security, especially in the digital health area. That's one side. I think first question to you. The second thing that I'd like to talk about is, I think the last year has been really, the one buzzword that's been really there is AI, right? So what is your view? Where do you see AI in healthcare? What are the opportunities you see, as well as the challenges I think you see for AI in healthcare? And tell us a bit about, this other buzzword, responsible AI. So what's your views on how do we get responsible AI probably in healthcare?
Right, it's a very good start. Okay, so been in the industry in data and AI for about 25 years. Started with Siemens Medical, writing code on computer-aided diagnostics that used to help radiologists. So yeah, AI is not new. But it's always the AI that takes the attention and everybody forgets about the data. And then after a little while, we wake up as scientists or engineers and wait a minute, I think we need to concentrate more on the data. Yeah, so in that sense, I think all the things that you mentioned, I think there is a huge amount of impedance mismatch between what AI can do and what the backend systems that power this AI can deliver. Right? So if you want to make precision medicine systems, right? So which are, of course, the next great thing to happen in medicine, which is very much feasible today with the AI's abilities. You require maybe 3 times more order of magnitude data access. You need genomics, you need cohort data, etc. And unless these backend systems bring, in terms of regulatory guidance or the guidance might exist, but the ability to interpret that and implement that is another thing, right? So there is a huge amount of gap that exists as we engage in the industry, where the guidance might exist in some form or shape, but someone's ability to read, interpret, and then implement it so that they are compliant, there is sort of lost in the middle there, right? Which is creating, I think, which is impeding the progress of AI in not just medicine but a lot of industries, right? So in Singapore, there are very clear regulations. MOH under Health Sciences Act publishes the AI guidelines. Very succulent, nothing too superfluous, like 600-page document. You can't read and interpret. It's quite accessible. And then you take that further to implement the responsible AI guidelines, right? And just on the data protection aspect, the patient data, considering it's a personal data, that part is not actually defined by the health ministry or the finance, MAS, for example. So that is a common denominator across industries. So the PDPA defines how that data needs to be managed. So that's pretty clear as well. Even in presence of that clarity, I still feel people are like, I can't implement this because I don't know what to do with it, right? So, yeah, I think it would really help if we as industry get together and take that guidance to one level further so that we become more confident in applying the responsible AI framework.
Thanks, Manpreet. I think you touched upon a very interesting aspect, and I'd like to bring Kanika in on this topic. Kanika, you've been working in terms of what should countries do as all of these new AI tools come in. I think we are likely to see a huge number of AI tools coming into healthcare over the next year or so. And I think, can you tell us a bit about the global initiative for AI in health that the WHO is working on, and what are your views on what should countries do to prepare for this? I don't know if I should use the tsunami of AI tools that are going to land on them, and they're not sure whether it's safe to use for their patients. They're not, how do they really prepare themselves for this? One second, Kanika. I think your audio, you can't hear the audio. Can you try now?
I believe I'm not audible yet. Okay, perfect. Thank you. Thanks so much for the question, and I really appreciate all the comments and feedback that we've received from all the other co-panelists. One of the speakers mentioned that a majority of the countries don't have enough standards, or any standards for that matter, to govern AI or AI for health, which is where the global initiative on AI for health really comes in to guide countries on what are the next steps that should be done in order to ensure that there is safe, effective AI in health especially. Manpreet also rightly pointed out that there is a gap between a policy and its implementation. So just to introduce you and to all the audience on what the Global Initiative on AI for Health talks about. It has 3 pillars, namely enabling, facilitating and implementing AI for health, where we're working on developing normative policies, where we're working on capacity building and really building that community of practice in order to ensure that AI for health actually happens, because there are established benefits of this technology. But to answer to your question, I think collaboration and cooperation is such an important factor when we talk about introducing AI or really having a successful AI technology in health. The global initiative is a tri-party collaboration between the World Health Organization, World Intellectual Property Organization, and the International Telecommunications Union. So having this kind of collaboration is helpful, and then working with different stakeholders in different countries also really builds on having an effective AI tool in different countries. To talk about the enabling pillar, which is having normative policies and guidances on AI for health, we've had 4 guidance documents since we've come up with this initiative. And in specific talking about responsible AI, there are 6 guiding principles having 18 recommendations in our guidance document called the Regulatory Considerations on AI for Health, where we are focusing on proper documentation and transparency, having a risk management, having analytical and clinical validation, ensuring data quality, engagement and collaboration, and lastly, privacy and data protection, which is sort of the hot topic, as you rightly mentioned. But at the core of all of this, I think the key principles are transparency and accountability. Once that is there will be patient safety and there will be confidence. And for all of this, there is a need for developing robust frameworks, which is where the Global Initiative does pop in order to guide countries on what are the initial steps to the next steps that need to be taken in order to ensure that countries are better prepared to incorporate AI in the healthcare system.
Thanks, Kanika. It's good, and I'm really happy to see that there's a leadership coming right up from the WHO in trying to help countries prepare as AI tools come in. I've also been noticing that there's been a humongous amount of investment that the VC industry has been pouring into kind of health tech companies, and so just an open question, and maybe Edward or Patota or others who have been working, Manpreet, if you've been working with the ecosystem, can talk about what do you see as the role, especially for public-private partnerships, and as this evolves in bringing out this more equitable access as well as more responsible AI kind of an ecosystem.
Yeah. How is the private roles here actually in the public-private collaboration? It's to give more perspective, basically. We open with everyone. And not only in terms of public-private partnership, we also would like to highlight the collaboration with the communities. We talk about the equitable access for healthcare. For our regulatory sandbox in Indonesia, we not only collaborate with the startups, with VCs, but we also collaborate with the communities for hearing and visually impaired. Because of course we would like to give access for all kinds of patients, so we also collaborate with the marginalized community, and we also plan to hyper-localize also our healthcare services for the technology, because that's actually the opportunity, at least in Indonesia. Because as Edward said as well, how we can give access to people with the Android 7 or 8, it's 12 years old. And we also think about how to give access with people from different abilities, from different language background, because in Indonesia we have like 500 local languages and so on. So that's not only the public and private partnership, but also specific civil communities on how to develop others' perspective, so we are not so biased on our vision from the capital of Indonesia. What about the people from region that even have a blind spot that internet access only since 6 p.m., stuff like that. So yeah, the public and private is also always open for discussion and give perspective, and almost every people from the health ecosystem in Indonesia has my personal contacts. They can contact me anytime, and they can also contact the Chief of Digital Transformation Office, our expert staff for the Ministry of Health. His contact is everywhere. Everyone can contact him 24/7. Usually, of course, he responds almost every chat with him. And that's also the same for the Minister of Health as well. For the Minister himself, he likes to get the feedback from the industry, from the citizen directly through his Instagram, and he shared it with us. So that's the position is not only on the public and private partnership, but also the civil society. We would like to highlight that in Indonesia because that's sometimes the group of people that's sometimes being forgotten, but we would like to highlight them as well as our initiative going forward for digital health. Thank you.
Thank you. Anybody else wants to comment on this?
Yeah, I guess my own view, obviously we have raised venture capital money, but we are focusing on equity. I think private capital is return seeking, and often it can perpetuate inequity. You know, a lot of AI innovations are going to naturally help more middle to upper income people and be inaccessible to the poor to some extent. But crucial role in innovation, absolutely right that it sits with the private sector, pro that. I think ultimately, you know, equity sits with government. You know, and we see that even in the UK. You know, even with the electronic medical records. I used to work for the Department of Health in digital strategy in the UK. There was 6 EMRs and they all got fragmented, and then eventually they had to make them all plug together, i.e. interoperability standards, and that cost hundreds of millions of pounds. So I think let private sector do its thing. Appreciate government has to do equity, especially going to lower income or bottom of the pyramid type segments, and put standards in early. I mean, every time I see Setu Sehat, I think it's a great idea. Same for ABHM in India. Because in some countries we work in and there is just a lack of standards, and that's not good, because then you have all this innovation spinning around, effectively creating silos. And at some point, you know, as countries get wealthier, we're going to expect the government to pick up the health system in its entirety. So yeah, I think you just have to consider with those lenses, and standards at the core are absolutely essential.
Great, thank you.
Yes, this PPP is becoming a new mode, right? We can create blending finance, we can do a lot of things, but also enable private sector. Governments should enable the private sector activities. In digital sphere and in connectivity, ICT connectivity, the private sector is a driving force. They are leaders, and government only have to do a better job in creating regulations and enabling environments. So the overall new fashion of interoperability, real-time management, all of that can happen very nicely if government would enable that space for digital cooperation between countries, not only within countries, but also between countries. Maybe between countries sometimes easier, the transboundary areas, so it can scale up to the villages also. Thank you.
Thanks, Ed. With that, I'd like to, we're going to be short on time, so I'd like to open that up to any questions that the audience might have.
My question is to Manpreet. As you know, AI models are data hungry, and we are in the age of data poverty kind of, where a lot of digital initiatives are still in PDF documents as a blueprint and not in the practice. So in such a age, if some AI models are being developed for healthcare, which might be based on non-inclusive data or probably very minimal data availability, how do you tackle the adoption of such tools of healthcare? And second question was to Kanika about global initiative for AI in health, which was launched last year, and now this year GIDH. how do you look at harmonizing these two initiatives, though launched 1 year apart? How do you see their implementation or in case of adoptions in various countries? Because one moves too fast and one is still struggling. Thank you.
Yeah, this is a complex question. I think it goes in many ways against the equitable aspects. But if a private sector company does have access to a private hospital data, they use that data set to create a predictive model or a large language model that does what it does, and that's their investment, then in some sense, well, they own that IP. Having said that, these models are only as good as the data sets. So unless the data access becomes more and more democratized, which means more data sets they have access to, the models can do much better. Right? So yeah, that's the bottleneck we have to, as industry, come together and remove. So even, for example, PubMed today, you need a subscription, and you could. A lot of researchers can benefit greatly if they all had access to it, for example. Right? But yeah, the AI model is very smart. It can learn from PubMed just as much as it knows ChatGPT, but ChatGPT, for example, doesn't have access to PubMed at this point in time. So yeah, that's a problem we need to find as industry a way to solve. From a responsibility perspective, also one of the key aspects in the responsible AI framework is around the fairness of the algorithm and the diversity of it, which means if your data set was biased in certain genetic types, certain races, then that model isn't really as good as it should be for equal use across all genetics, for example. So that's another challenge you have in terms of how do you remove that bias. Yeah, so when the face recognition systems came first, because they were trained in North America, they were not very good with the Asian faces. So, but over time, maybe at Microsoft worked on removing that bias and making the data equally diverse, so that they start. I'm just giving a very simple example. And of course, the cancer prediction is much more trickier with small amount of genetic cohorts. So yeah, those aspects I think we need to iron out as an industry, and if the sooner we can do it, the more benefit we can bring to humanity.
I think even governments have a role to play in the sense of creating certain data sets at a national level that's representative of many use cases, especially when it comes to ultimately AI tool validation before they roll it out. They're going to have to sign off on what's the basis on which they're signing off. So I think we will see governments also start to come in and say, okay, for my population or my this one, do I have really a representative data set that I can use for these? Kanika?
Okay, just want to make sure I'm audible.
Yes.
Perfect, thanks. To answer to your question on the global initiative on digital health and then the global initiative on AI for health, they in fact come from the same department, which is the Digital Health and Innovation Department at WHO. The global initiative on digital health came about via the G20 presidency in India, and it focuses on a network of networks, but I will speak more clearly and deeply about the global initiative.
We have a network resilience issue. Yeah.
Is it better now? Oh, thanks. I was saying that I am speaking more for the global initiative on AI for health, which came from a focus group between the World Health Organization and the International Telecommunications Union back in 2018, focusing on one of the niche between many emerging technologies, namely the artificial intelligence on AI for health. And our focus is on creating normative policies governing AI for health, building a community of practice, having workshops and hosting all sorts of courses to better equip masses at large and become more comfortable around the feeling more comfortable on our
We had a bit of an internet issue, but we're also running out of time, so I'm going to have to take a pause, pass on that. With that, I'd like to invite Simi from Access Health to come in and give us a few closing comments.
Hi everyone. Thank you Kiran and our esteemed panelists for that riveting conversation at Access Health and as a member of the digital health team. We're looking forward to continuing our work on strengthening digital health policies and implementation. And as Supriya outlined, the areas we're looking at are the use of responsible AI and also community-powered or community-focused development of digital health solutions. So when I reflect on that, on the conversation that we just had, and a conversation that I hope we can continue to build on, some points that I've noted as points of reflection are, number one, if I start with Ida, is building e-resilience. And when we do this, not to just look at the sector that we're working on. For example, you're looking far ahead to understand in this sector of climate and digital health, what is the resilience that can be built, keeping that in mind. So that was something to keep in mind. And then, Ed, you mentioned we are moving fast. AI is growing by leaps and bounds, but we cannot forget communities that are working with dumb phones, so to say, who are speaking multiple languages that these technologies may not cater to, and who may not even have internet access. And then, Tota, you mentioned that being transparent, how important it is to share with users what technology is being used, what data is being captured. So this is another principle that we will keep in mind. Manpreet, what you touched on is something that we have been reflecting on over the past couple of years. The policies come in, the regulations come in, regulatory guidance comes in, but people don't understand how to apply that. That capacity building has to be there, that hand-holding has to be there for these technologies to be effectively complied with, for that security and trust to be built. So that was an important point to note as well. And Kanika, you mentioned the need for robust frameworks. And Kiran, you mentioned when it comes to data, it's not just industry who has to play a role, but it is also governments who already are focused on seeing that they have the data to make inclusive database decisions. But it's this collaboration that's needed, and that is the theme that I saw in all of your responses. We need collaboration, we need cooperation. This is very close to Access Health as a multi-stakeholder approach, and we look forward to taking this conversation with you forward as we continue our digital health initiatives. Thank you so much for your time today.